Aloha, welcome back to General Pharmacology. Let's move the PowerPoint slides and get started. Today we have a lot to cover. And even more basic pharmacology. There are 3 sections of basic pharmacology. They are really some of the most important foundations that you can have in pharmacology. A lot of the board questions that I see pertain to the material in 1.3, 1.4, and 1.5. So let's talk about more principles in basic pharmacology. Biotransformation, biological changing transformation. Biotransformation is the chemical changing of a substance in the body. And so in pharmacology, we'll talk about the biotransformation of a drug, or just the transformation of a drug. And what I want you to keep in mind as we go through this is this biotransformation system. It's the same system that you use to not only detoxify the body, it's the same system that we use to transform nutrients. It's the same system we're going to use to transform drugs. And so you'll notice as we go through, the body, the liver, and the rest of the cells have these transformation enzymes. And they're designed not only to eliminate toxins from the body, but they also transform nutrients that we need. And we rely on this system for the transformation of medications as well. And the basic strategy is this. We like to say the liver does this, but all of the cells participate in biotransformation. And you'll notice that the strategy involved is to turn fat-soluble substances into water-soluble substances by attaching little polar groups, attaching oxygens, or even bigger molecules. And what we're trying to do is make these fat-soluble substances water-soluble so they can be easily eliminated by the kidney. And so regardless of what kind of transformation systems you use, or the transformation systems that you study, you'll see that the philosophy of the body is to add water solubility to these fat-soluble substances. These transformation enzymes, we'll call them the CYP enzymes, we'll call them the cytochrome P450 enzymes. They're all the same. And then there's all sorts of cytochromes that have different numbers. And if you have Katzung's book, I'm sure that's very extensive. For the purpose of this course, we're going to throw all the CYP enzymes together. They metabolize thousands of compounds, whether endogenous or exogenous. Your liver is the main place this occurs, but again, this occurs everywhere. All right, well, the CYP enzymes can metabolize different chemicals and substrates. So when we talked about pharmacology and locks and keys, we said, oh, well, this drug can only interact with this receptor because they're perfectly matched to each other. CYP enzymes are not that way. The CYP enzymes can recognize and metabolize all sorts of different chemicals and substrates. So here's my cartoon of a CYP enzyme, and it's supposed to be showing you grinding up these little things, these little chemical structures here, and turning them into different chemical structures. Anyway, that's my cartoon of a CYP enzyme. It is a protein. We've made it red colored because that's what cytochrome P450. P450 is the wavelength of light that looks like liver, and cytocell chrome. That's why my protein has this color to it. Remember aromatic rings? We talked about aromatic rings. Aromatic rings are essential to functions in the body, but aromatic rings in other forms can be toxic as well. Like polycyclic aromatic rings are toxins. And your liver and your body sees these aromatic rings. It's going to start doing things to those aromatic rings, and you're going to notice it's going to put oxygen groups on those aromatic rings. It's going to conjugate those aromatic rings, and we're going to go through that right now. But keep in mind that phenylalanine has an aromatic ring on it, and your body oxidizes it to turn it into a nutrient that we need. And so keep in mind that these chemical systems are not only trying to eliminate toxins, but transform nutrients using the same system. Like phenylalanine, it's essential amino acid, and because of all these toxins running around with these aromatic rings, your liver sees that, and your cytochrome enzymes, they see that, and they're like, well, we better do something about that. Well, it sees these aromatic rings. It thinks the same thing. We better do something about this right here. And so you'll notice that phenylalanine is transformed into tyrosine, and we'll have a special name for that enzyme, but I can assure you that enzyme is part of this cytochrome system that sees these little aromatic rings and thinks, oh, we better make that more water soluble. And by sticking a hydroxide group on it, that oxygen group on it, we've oxidized that ring. And so when we oxidize this ring, we've turned an essential amino acid into an amino acid that we use, but this is the same system that we use to detoxify polycyclic aromatic rings and other toxic aromatic rings. Well, when we talk about steroid synthesis in section 4, I want you to see all these complex ring structures, and that the steroid synthesis is just quite simply achieved by taking this complex ring structure like cholesterol and oxidizing it at all these different places. And so we'll talk about aldosterone, our mineral corticoid, and we'll talk about cortisone, which is just a glucocorticoid. Hydrocortisone is a glucocorticoid. I think those are the only two mentioned. But in this slide, however, if you look at all of the steroid synthesis that comes from cholesterol, it's just all these various steps of oxidation. By the way, cholesterol, A, B, C, D, those are my sterol rings. And so anything in pharmacology that is a steroid is just quite simply based on cholesterol. How they use steroid in TV land is completely different than how we use steroid in clinical pharmacology. And again, a steroid is quite simply anything that's based on these sterol rings that usually start with cholesterol. And so what I wanted you to see is that your body is always processing these rings. It recognizes them as potential toxins. However, we've used these systems to also create hormones and nutrients that we need. And we do the same. These same systems are what we use for drug transformation. Because most drugs are fat soluble or strongly bound to proteins and are not readily filtered by the kidneys unless they're transformed in some way, and toxins are the same way as well. And so it's one system dealing with not only toxins but nutrients and medications. So again, the body's constantly exposed to all sorts of foreign substances. It's always trying to transform these substances. If you think about the stuff that you eat between all the phospholipid bilayers and the proteins and all the other stuff in the botanicals, there's just countless chemicals in those plants. And I'm talking about chemicals in terms of a pharmacology course. In TV, chemicals are some kind of bad thing, but in chemistry and physics, everything is made of some kind of particle which has to do with chemistry. And so remember, pharmacology is chemical interaction between medications and their receptors. And when you think about the stuff that you eat, you're exposed to all sorts of substances. And then you think about the history of humankind and all the horrible things it's put in its mouth in the process, you can see where we're going with this. And so as soon as you eat anything, that blood is carried to the portal blood supply, the liver takes a look at it, and the metabolic machinery starts changing the things that you have eaten. One of the major strategies is this. We're trying to take a fat-soluble toxin and make it water-soluble so it's less toxic, because being water-soluble, it's easily eliminated through the kidneys. And so here's this fat-soluble toxin that has been identified by a CYP enzyme, and it's going to oxidate. It's going to oxidize that fat-soluble substance to make it water-soluble so it can be eliminated through the kidneys. And so this is called a phase 1 reaction. Please do not be confused and think that phase 1 has to happen before phase 2. That is not the case at all. We can have phase red and phase blue because they don't have to occur in any order, and some drugs undergo both. Some drugs will undergo phase 1 reactions and phase 2 reactions. All right, so phase 1 reactions are the same thing as oxidations. There's all sorts of oxidation steps. They don't have to just be oxygens. But loss of electrons is oxidation. And so when we take this fat-soluble substance and we oxidize it, we've made it more water-soluble. And so adding those little hydroxide groups, those oxygen groups, on my cartoon is what oxidation is. Oxidation is far more complex than that, although hydroxides are one of the oxidation steps. And so when we take these toxins and oxidize them, making them more water soluble, we call that a phase 1 reaction, a phase 1 oxidation. Well, the same thing happens with drugs. When we give a medication, that medication is going to be oxidized, making it more water soluble. That's called a phase 1 oxidation. So if you're reading about medications and it says, oh, well, they undergo a phase 1 reaction, well, that's what they're talking about here. The liver and the CYP enzymes everywhere else, they recognize this drug, they see this drug, and they start oxidizing it. And by oxidizing the drug, it makes it more water soluble, makes it more easily to eliminate through the kidneys. Nutrients undergo this as well. We saw this with phenylalanine going to tyrosine. When we actually do that, we're not going to call that a phase 1 reaction, an oxidation, but in reality, that's really what has happened. It's the same family of enzymes. They're related to each other. And so here we've taken phenylalanine and hydroxylated it to make tyrosine. Again, that's considered an oxidation step, a phase 1 reaction. All right, well, let's talk about conjugation. Again, with oxidation, there's a lot of steps. There's a lot of different ways to oxidize. They don't have to be just hydroxide groups. Same thing with conjugation. When we conjugate something, we're taking a fat-soluble substance and then we're putting these large ring structures, very similar to glucose, onto the fat-soluble toxin to make it water-soluble. And so if you took something like a glucose molecule and stuck it on this fat-soluble toxin, it'd make it really water-soluble in one big step. And so this is called conjugation, taking a large molecule and attaching it to the fat-soluble molecule to make it even more water-soluble. And so that's called conjugation. That's called phase 2 reactions. Phase 2 reactions are conjugations. But again, phase 2 can occur first before phase 1. Many drugs undergo both and both at the same time. And so phase 1 and phase 2 don't imply any kind of order. But what I wanted you to see, the conjugation is just adding these ring structures. And there's more than this. The glucose, glutathione, glucuronic acid are some of the conjugations you'll see. I read about another conjugation yesterday, and the list is long. All right, so this is what conjugation is. And so when toxins are conjugated with highly polar glucose-like molecules, then this makes them very water-soluble, and this is called a phase 2 conjugation. And so maybe you've heard of bilirubin. Maybe you've heard of conjugated and unconjugated bilirubin. If you're in the surgery business and you look at people with gallbladder disease, liver disease, common bile duct obstruction, then you're going to definitely want to know the difference between conjugated and unconjugated bilirubin. So when your body makes hemoglobin, your body makes blood cells. Those blood cells, they don't last very long. They get broken down. That hemoglobin gets broken down. And when the hemoglobin gets broken down, it turns into bilirubin. And bilirubin is really, really, really fat soluble and really, really toxic. Your body when it breaks down the hemoglobin, it generates this toxin called bilirubin, and it's unconjugated, and it'll stick to the brain and it'll stick in the fat parts of the brain, the lipids of the brain, and other lipid parts of the body. It becomes very toxic very quickly. Well, the liver conjugates the bilirubin into a water-soluble form. So if you're doing a urinalysis and you're testing for bilirubin, well, the bilirubin that's in the urine is water-soluble. And so by definition, it must be conjugated bilirubin. And so the liver will undergo this step right here, take that bilirubin, that toxic bilirubin, make conjugated bilirubin. And so when this step occurs, when we see conjugated bilirubin, then we know that the liver is conjugating the bilirubin. And if there's a buildup of conjugated bilirubin, maybe the obstruction is in the common bile duct. If there's a buildup of unconjugated bilirubin and no conjugated unconjugated bilirubin high, conjugated bilirubin low, tells us the liver is not working properly to conjugate the bilirubin. So if you're on a surgical service doing any kind of biliary care, You'll know the difference between conjugated and unconjugated bilirubin, and the conjugation step is this right here. The bilirubin going through the liver, going through the CYP enzymes, and being conjugated with a glucose-like molecule. Drugs undergo this as well. We can conjugate drugs to turn them into we can take drugs, your body will take the medications, conjugate them to make them renally eliminated. All right. And that's all done with these CYP enzymes. There is a slide missing. What is missing? Let me find it. That's what happens when I review these things. It's down there. All right. The slide I'm looking for did show up. All right, let's talk a little bit about inhibition and induction. I think induction might come first in the notes. We're going to talk about inhibition first because it's much easier to talk about. Again, when we're talking about enzyme induction and enzyme inhibition, we're talking about the cytochrome P450 enzyme system, the CYP enzyme systems, and they have a way of being able to know when they're needed and react. Sometimes they're fooled and react in the wrong direction. So CYP enzymes, they can make more of themselves or less of themselves depending on the situation. And certain medications are going to affect whether the CYP enzymes think they should make more of themselves or tell the CYP enzymes that they've made too many of themselves. And that's what inhibition and induction is. When you have a drug that's an enzyme inhibitor, it's basically inhibiting the action of that enzyme right here, inhibiting this. And so a drug inhibitor is going to slow this down. We can think about the CYP enzyme being like a garbage disposal. And so if the garbage disposal is blocked, inhibited, then we end up with more stuff that's supposed to go in the garbage disposal. So that's why enzyme inhibition, garbage disposal blockage, results in decreased activity of the garbage disposal, but you end up with increased activity of whatever's supposed to be going in the garbage disposal. So enzyme inhibitors increase the pharmacologic action of a drug. And so if somebody's taking a medication and they're taking another medication that's an inhibitor at the same time, the other medication is just going to increase its effect. Because it's not being metabolized, it's not being run through the garbage disposal because the garbage disposal is blocked. So here's my garbage disposal of CYP enzymes, and notice that the more I use the medication, the more it inhibits CYP enzymes. And if we're blocking the action of CYP enzymes, if we're decreasing the enzyme activity, if this drug causes enzyme inhibition, what do we end up with? More action of that drug. And so drugs that are enzyme inhibitors are increasing their pharmacologic action over time. And this is confusing to a lot of people. So enzyme inhibitors not only increase the pharmacologic action of themselves, enzyme inhibitors increase the pharmacologic action of all the other drugs that rely on this garbage disposal to be eliminated. And so if you block the garbage disposal that eliminates drug, you're going to end up with more drug. So inhibiting the enzyme results in more drug. Simple enough. Depakote, a seizure medication, isoniazid, anti-tubercular drug, Tagamet for the stomach. Ketoconazole is antifungal, diflucan. A lot of the antifungal drugs have enzyme issues. Alcohol, bad. Chloramphenicol is an enzyme inhibitor. Erythromycin, commonly used medication. The sulfonamides, commonly used in diabetes, at least they were commonly used in diabetes. Ciprofloxacin, an antibiotic. Omeprazole, Prilosec, commonly used in the hospital, is an enzyme inhibitor. Everybody who comes to the hospital ends up on some H2 blocker, and Prilosec is an enzyme inhibitor. Metronidazole is a type of antimicrobial agent. It's an enzyme inhibitor. Grapefruit juice. You'll see, do not take grapefruit juice when you're using these other medications because grapefruit juice interferes with the enzymes in the gastrointestinal tract, decreasing their function. And so you'll hear about grapefruit juice being an enzyme inhibitor. I don't expect you to memorize all these, but if you take a look at them, maybe you'll remember especially things like Prilosec. And maybe you'll get a phone call and like, well, if you take these two medications if you give the patient these two medications at the same time, you're going to get more of a pharmacologic effect over there. That's what they mean by enzyme inhibitors. So take some time to wrap your head around that. A lot of people who eke through a pharmacology class never understand this concept. All right, well, now that we know what inhibition is, that's the drug turning down the garbage disposal. Well, we can have the opposite occur. We can have drugs that speed up the garbage disposal. So the more these enzymes are exposed to this drug, the more upregulated the enzymes become. And that's called induction, inducing those enzymes. So some drugs speed up the cytochrome P450 system. They induce the P450 system, so they increase the amount of cytochrome P450 enzymes. There's my cartoon. All right, so here, the more we're exposed to this medication, the more it causes the CYP enzymes to expand, or to make more enzymes and have more action. All right, well, if a drug is turning up the volume on the garbage disposal, what's going to happen to the activity of that drug? That activity of the drug is going to decrease because there's more garbage disposal. Getting rid of the drug, and that applies to all the other drugs that rely on this disposal system. And so if we give somebody an inducer and speed up all the CYP enzyme system, then we're going to end up with less drug activity. And so inducers result in not only the increased metabolism of the drug, that results in decreased pharmacologic action of the drug. Phenobarbital, the barbiturates, phenytoin, tegretol. We talked about dilantin. It's an enzyme inducer. Rifampin, an antitubercular. Sulfonylureas, we will use in diabetes. Alcohol, again, griseofulvin, an antifungal. Let me take a quick look back here since I'm actually paying attention. Sulfonamides. Yeah. And sulfonylureas, great. We use sulfonylureas in diabetes mellitus. They are sulfonamides related to Lasix and hydrochlorothiazide, so for those of you keeping score. Human CYP enzymes are membrane-bound, and they're found on the inner membranes of mitochondria and the endoplasmic reticulum of cells, and there's lots of this stuff in the liver as well. And so we like to blame the liver for all this biotransformation, but it occurs peripherally in the gastrointestinal tract, everywhere else as well. And if you read carefully, you'll see that biotransformation occurs in all sorts of interesting places. Remember we talked about the first pass effect with standard medications that have bioavailability. It's not 100%. Oral medications that do not have 100% bioavailability. They're swallowed and then they're absorbed past the gastrointestinal tract, and the medication is taken by the portal blood supply to the liver for processing. And then the liver will see this medication and process it, make it inactive. And so with the first pass effect, maybe like when we were talking about beta blockers, you can take 100 milligram of a beta blocker, but if it only has 10% bioavailability, that means if we take 100 milligrams by mouth, only 10 milligrams ends up in blood supply. The other 90% was metabolized into an inactive form due to the first pass effect. And so this is the standard thinking with medications. However, there's something out there called prodrugs. Today I read them as logically conceived, rationally conceived. That means these drugs are designed to be inactive until they undergo transformation, and then when they undergo transformation, they're transformed into an active form. And this is what a prodrug is. And we see more and more and more prodrugs in pharmacology. One of the reasons is patent protection. It's hard to, a lot of the drugs that are all advertised as being different, well, they're all different prodrugs, and then once they undergo metabolism, they all end up being the same drug inside of the body. And so there's all sorts of interesting reasons we're seeing prodrugs used more and more. And so when the prodrugs undergo their first pass effect, they're converted into their active forms. And so here we have a prodrug, and it's undergoing metabolism into its active form. When we talk about antimicrobial agents, antibiotics, Prontosil, the first sulfonamide antibiotic, was a prodrug. That meant when it was in the Petri dish, it had no effect whatsoever. If they put this Prontosil in the Petri dish with the bacteria, well, it didn't have any effect at all. But if you put it in a mammal, if you put the Prontosil in a mammal, what happens is it undergoes biotransformation. Then what we end up with is an active drug. There's a drug on the market today called Xeloda, and Xeloda is just quite simple. Xeloda is the prodrug for a chemotherapeutic agent called 5-FU. Now, we can't swallow 5-FU. 5-fluorouracil has to be given IV. It's a very cytotoxic drug. It can cause all sorts of problems if we don't deliver it IV properly. If somebody drank the 5-FU, it would destroy their gastrointestinal, it would destroy their esophagus. But they came up with a way of making the 5-FU the product of metabolism. And so capecitabine, Xeloda, is a prodrug that the body, actually the cancer cells, convert into an active form inside of the cancer cells, being 5-FU. And so we're seeing this more and more and more. This prodrug, all the different prodrugs that can be metabolized into an active form. When you read about the medications on the market for herpes, there's all sorts of different types of medications for herpes. However, when they undergo the first pass effect, they all end up being the same medication. We'll try to talk about the prodrugs, the family of prodrugs that are all related to the same active drug once they undergo first pass. I talked about this. Prontosil was the first sulfonamide antibiotic and had no antibacterial properties in a Petri dish, which is called in vitro. When we're inside of a test tube or a Petri dish, that's out of the body, that's in vitro. But it had excellent properties after undergoing biotransformation. That's called in vivo. I thought I had that slide in there. In vivo, I-N-V-I-V-O. When you see commercials for medications, they try to convince you that, oh, this medication is going to work exactly the same way in everyone. That's not true at all. And so here we've gone and spent all this time talking about metabolism of drugs. We've talked about kinetics, about how the body deals with a drug. And even though we've talked about all the similarities, you do want to know that, well, everybody's different. This person's not going to be metabolizing the drug exactly like that person over there. Now, you will have a big group of people that, on average, metabolize drugs just like everybody else. But you're going to always have these outliers. There's always 21%, 22% of the people that don't fit in within the first standard deviation. And so a quarter of the people out there aren't normal. And so that's due to individual differences, genetic differences. There's this thing called pharmacogenomics, where your genetics, an understanding of your genetics is essential to us understanding how the medication works in you. When we get to cancer and chemotherapy, there will be things that are related to genetics that determine what medications that we use. And so understanding somebody's genome, understanding somebody's genetic predisposition to metabolize a drug a certain way is a new thing in pharmacology, despite the people on TV convincing you that, well, this medication is going to affect everyone the same, except all this fine print that goes by at the end. The other things in your diet are going to affect enzyme induction, enzyme inhibition, just like environmental factors. The older we get, the less we metabolize, like a young person. Males metabolize differently than females with certain drugs. There are drug-drug interactions, and we talked about that with enzyme induction and protein binding. Disease processes, if somebody has liver failure, they're certainly going to metabolize acetaminophen, Tylenol differently than somebody who has a healthy liver. So if you see this question, the answer is always all of the above. And again, 3/4 of the people are going to fit the normal profile, and the other quarter, they're not going to fit the normal profile. And so be on the lookout for this. Realize that how we metabolize drugs is dependent on a lot of factors. In your notes, we'll talk about botanicals and nutritional supplements. but we're going to leave them out of the lecture for the most part today so I can get done on time. All right, so the medical use of botanicals in their natural unprocessed form undoubtedly began when the first intelligent animals noticed that certain foods altered bodily functions. Wow, this is the history of pharmacology in a nutshell right here. Pharmacology did not start in a factory somewhere full of biochemists. Pharmacology started from very primitive creatures realizing that if they ate certain things, their bodily functions would change. And that's something that intelligent creatures needed to realize early on. There are certain things that we can eat that make us very ill, and we won't eat them again, hopefully. But there's other things that we can eat that make us feel better and change our body functions. And so we first started learning about this before the history of mankind, and then we have been paying pretty close attention since then. So there's all sorts of information about the historic use of botanicals and how they emerged into modern pharmacology. However, we've turned it into a business, and now we have consumers who embrace the use of botanicals as a natural, drug-free approach to their health care, and that's fine. Do keep in mind that in a pharmacology class, toxins are all natural. And so they are synthesized by plants and animals, and so I'll hear somebody that's like, oh, well, this is all natural. I'm like, well, toxins are all natural as well. All sorts of botanical substances have been used in traditional medicine. Our understanding of morphine, digitalis, atropine, the polyketides, the antimicrobial agents, the antibiotics that we'll talk about, they all started as botanical substances before we had any idea what morphine, digitalis, atropine, and polyketides actually were. There were intelligent creatures that realized that certain plants had these properties of killing pain, stopping the pounding in the chest. Atropine has all sorts of uses. Polyketides is preventing infection, is something that's gone back for a long time. And so they call them alternative medicinal substances because they're available over the counter without a prescription. These are nutritional supplements. They're not drugs. And so unlike over-the-counter medications, alternative medicinals are not regulated by law because they're considered dietary supplements. They're not drugs. And so it's really hard to teach about the pharmacology of our alternative medicinals when the active ingredients in a botanical, we're not sure what the active ingredients are. There are a bazillion of them, and they're not required by law to explain them in a professional pharmacology manner. And so the over-the-counter medications like alternative medicinals are by law, not by pharmacology, by law, considered dietary supplements, not drugs. But I can assure you that a drug is any substance that brings about a biologic function through its chemical action. So if a botanical causes the bowels to move more frequently, it's a drug. If it causes any kind of change in the body's regulatory systems, it's a drug. And so these are medications. When we're using alternative medicinals, we're using them as medications because we're attempting to bring about a bodily function. So the alternative medicinals, despite what they say in the law books, they are drugs, they are chemicals. Plenty have beneficial effects, plenty have toxic effects. In the European Union, they spend a lot more time and energy studying these, and so there is a European compendium of the alternative medicinals. But after following that for about 30 years, and that stuff has changed, it's really hard to include this stuff in a professional pharmacology course because, again, the plant substances, there's so many of them, it's impossible to say which one is interacting with which receptor, and those are sorts of things we kind of want to know in a pharmacology class. The botanical substances, which are made of plants that contain all sorts of plant chemicals, are going to be distinguished from purified nutritional substances where they take a plant substance and then they separate something out, just like they do in the factory of a pharmacology plant, a pharmaceutical plant. And that stuff's pretty explained in your notes. All right, let's talk about how drugs get all those crazy names. And I came across this cartoon today. Somebody has a diploma hanging on the wall, and he's won a Pulitzer Prize for his imaginative incredible drug name. And so there are people who, I don't think they win Pulitzers, but they make their money by coming up with drug names. So let's see where that comes from. Well, believe it or not, drugs actually have three names: a chemical name, a generic name, and then something called the trade name. The chemical name is just what chemists would call it. A generic name is something that we regulate, and so all of the chemical names that are the same, any chemical has the same generic name, but it can have all sorts of different trade names. And so let's go through that. But this is what I want you to keep in mind. There's a chemical name. We never use that in pharmacology unless we're chemists. Then there's a generic name of medication. By convention, the near entirety of time, generics are not capitalized. And then trade names, when you read the book, they'll have rights reserved because the name of that drug is intellectual property for that corporation, and so they reserve the rights. And so you'll see that R everywhere except my curriculum. We take that out because it's a distraction. So why do drugs have so many names? Well, there's an interesting reason how that came about, and now that we're at now, maybe we should try to rethink these things. All right, so here's plus minus 1 isopropyl amino 3 para 2 methoxyethyl phenoxy 2 propanol levo plus tartrate. All right, well, nobody's going to write a prescription about that. But that drug is metoprolol. Regardless of where you are in the world, if you manufacture this right here, you're going to call it metoprolol. All right. So this always translates into its generic USP name. All right. Well, in one pharmaceutical company, they make metoprolol, and they called it low pressor. They took their metoprolol, and they said low blood pressure, low pressor. Oh, that's a great name for a drug. And so they make metoprolol, and they call it low pressor. Somewhere in another factory, someone makes exactly the same metoprolol. Now, they'll tell you there's some difference between toprolol and low pressor, but in a different factory at a different company, they make exactly the same metoprolol, and they call it toprol. That'll be easy to remember that that's metoprolol. And so low pressor and toprol are exactly the same drug with two different names depending on the manufacturer. And again, these trade names are intellectual property owned by the drug company. The word metoprolol is a standardized name given to this chemical substance right here. All right, so nobody uses the chemical name. One of the reasons that we started using trade names back in the Stone Age is that the generic names were easily confused with each other in the same class: metoprolol, propranolol, labetalol, timolol. It's just a lot of beta blockers. And at the time we started all this trade name business, we thought giving things a trade name would make it a little easier, prevent all this confusion of drugs looking the same. So the trade names were going to give us an easy, catchy way to remember a drug, like low pressor. You know, that's easier to remember, like low pressor, than metoprolol. Is that metoprolol or labetalol or timolol? Right. So toprol, oh yeah, that's metoprolol. All right. And so the trade name gives us this easy, catchy way to remember a drug. The generic names tend to be a little bit boring and sound alike. And so I get a question frequently. I hear this all the time, and everybody has a different answer than mine. What should we use as a drug name? Well, we should only use the generic names. I don't think that's a very good idea. We should only use the trade names. That's not a very good idea. We need to use the name that best communicates what it is that we're trying to do. All right? And so if low pressor is the best way for you to communicate the idea, then low pressor needs to be the name you use. If metoprolol is the name that you use, then metoprolol needs to be the name that you use. And we see this all the time, like there's certain places like Kaiser Permanente, and they only use generic names. They try not to use trade names. And yeah, you talk to the doctors and talk to the pharmacists, and we use trade names all the time, It just says the generic name on the label. And so get used to the fact that drugs have a generic name, and then they might have several different trade names. And so you'll read a book and it'll say, oh, metoprolol, that's low pressure. Well, then you read some other book and they'll say metoprolol. Oh, well, that's toprol. All right, so one generic name can have multiple trade names. All right, so do you know what that is? I only know what that is because these are my slides. That's diphenhydramine. Do you know what diphenhydramine is? Diphenhydramine's Benadryl. Benadryl is the trade name for diphenhydramine. Now, what's really interesting, when I was making this lecture, well, it's kind of interesting. When I was making this lecture, I'm driving around Oahu, and there's this commercial that I'm sure people have seen. And there's the guy who's like, well, I take Benadryl as an antihistamine, and it doesn't make me sleepy, as if, you know, Benadryl making people sleepy. Well, that only happens to sissies. I mean, he's looking at the camera accusing people of taking Benadryl and getting sleepy. It doesn't make me sleepy, like it's some big lie. All right, well, then you take diphenhydramine and you go to the other side, and they'll put diphenhydramine, you go to another counter, they put diphenhydramine and stuff as a sleep aid, like it's guaranteed to make you go to sleep. And so you take diphenhydramine for allergy, and the guy on TV will go, well, it doesn't make me sleepy. You've got to be some kind of sissy to fall asleep with diphenhydramine. And then you have another commercial, and they put diphenhydramine in a sleep aid. And if you take diphenhydramine, you're guaranteed to go to sleep because they use a different trade name than Benadryl. And that is quite simply deceptive marketing, and that's pretty much all we see with this sort of marketing. And so I need you guys to know how to read the labels and know the difference between effects and unwanted effects. I don't really think of them as side effects because diphenhydramine makes you sleepy. And if you're taking it as an antihistamine, then sleep is an unwanted effect. Sleep is a side effect. But you go over and take the same diphenhydramine as a sleep aid, then sleep is the wanted effect. It's not the side effect. And I'll tell you right now, you get to learn to read the labels. You go over and find 25 milligrams of diphenhydramine over in the allergy section. It'll cost about $2 more than the diphenhydramine that's in the sleep section. The exact same medications in different shelves, different prices, because we know diphenhydramine is a great antihistamine. As a sleep aid, not so great, despite what they say on TV. So that's my Benadryl story. Now there's more to this Benadryl story. Diphenhydramine comes in a liquid, 12.5 milligrams and 5 cc's. And notice that cherry flavor that they put in it. Something else they do is they put red food coloring in it, which is completely unnecessary. Somewhere in the 1930s, someone decided that putting food coloring in things made it taste better, made them psychologically believe it tastes better. But I know that I've had white carpet in a rental property with young triplets, and the red food coloring has gotten all over the carpet, and it takes a professional steam cleaner to get it out of the carpet. And I'm like, well, gee, if the red food coloring is sticking so well to the carpet, there's really no reason to be putting red food coloring in children's medication to make kids think it tastes like cherry. And so we'll move on with our regularly scheduled program. Here's diphenhydramine in a nice cherry-flavored liquid, 12.5 milligrams and 5 cc's. So here's children's Benadryl allergy. Notice that nice cherry-flavored liquid. Well, Diphen-AF. What's the difference between Benadryl allergy and Diphen-AF? Well, you'd have to read the label. What does it say on the label? Diphenhydramine comes in a liquid, 12.5 milligrams and 5 cc's. Notice the red food coloring, which is completely unnecessary. However, we can get some medications without food coloring, and we need to make sure we get more medications without unnecessary food coloring. But again, that nice cherry-flavored liquid, 12.5 milligrams and 5 cc's. All right, well, here's CVS allergy. Notice the nice cherry-flavored liquid and the red food coloring. And what is it? It's diphenhydramine, 12.5 milligrams and 5 cc's. Premier value, children's allergy. Notice that red food coloring and the nice cherry-flavored liquid. What's in it? Diphenhydramine, 12.5 milligrams and 5 cc's. Diphenhist. What's in Diphenhist? I'll give you a hint. That's a nice cherry-flavored, nice cherry flavor and the red food coloring. And what's in Diphenhist? Diphenhydramine, 12.5 milligrams and 5 cc's. All right, good sense. antihistamine allergy relief. Oh, pictures of kids. It must be safe to give this to kids. Well, it depends on how much you give as long as you follow the instructions. All right, notice the nice cherry flavored, we can't see the red food coloring. And what is it? Diphenhydramine, 12.5 milligrams in 5 cc's. Gold Line manufacturers make something called hydramine liquid. What's in hydramine liquid? Well, there's a nice cherry flavor and red food coloring. You can't see that, but it's diphenhydramine, 12.5 milligrams in 5 cc's. Altaril, an alternative to Benadryl. Wow, what a great name. You probably got a Pulitzer Prize for that. What's an Altaril? Benadryl, 12.5 milligrams in 5 cc's. Notice the nice cherry flavor and the red food coloring. Waldrill. What's in Waldrill? Diphenhydramine, 12.5 milligrams in 5 cc's. Notice the red food coloring and the nice cherry flavor. And so you got to read the labels because the packages mean nothing. The names mean nothing. Those are quite simply marketing campaigns because what's inside of the bottle? Exactly the same stuff. Now sometimes the flavors will be a little bit different. It's not quite the same cherry. It's not quite the same sweet. The additives might be different, but it is the same chemical, diphenhydramine, 12.5 milligrams for each cc in each of these. And so you go to the drugstore and you have a million choices, and yet they all have the same drug in them. And that's what I want you to be aware of as a consumer, not to be fooled by the trade names. Look at the label and see what the actual drug is, because you have to be able to look this stuff up. My favorite place to find stuff is drugs.com. Make sure that you're looking at the professional label, not consumer information. So it says, ask your doctor if. Well, if you're the doctor, you're not going to tell the patient, ask your doctor. You are the doctor. Ask your nurse. You are the nurse. All right, so you want to read professional information that is designed for professional healthcare workers, because that's what this class is for. If you Google the words Daily Med, these people come up, dailymed.org. Maybe they've been gotten rid of by now. Not them. Please do not use dailymed.org. When you Google the words Daily Med, then dailymed.nlm.nationalinstituteofhealth.gov comes up. And so this is the National Library of Medicine, National Institute of Health for the government. And they have Daily Med. And these are the FDA monographs, the drug labels that we're going to talk about during this course. They're stored there for free. You know, there's places that'll charge you money to give you this when you can just go there and get it for free. And not only are the packaged labels here, there's all sorts of interesting information about veterinarian medicine. There's stuff in there about breastfeeding and medications. And so this is a great website to get your medication descriptions. I like using this too because it'll give me classes of drugs. I can sit down and say, well, what classes of drugs do we have to treat diabetes? And I'm like, okay, what is that? I've not seen that. And then you go look at it, and I'm like, oh, well, that's just that over there. Right, so I like using drugs.com, but make sure you use professional prescribing information when you're looking at that. All right, and there's a place in the syllabus. There's a blurb in the syllabus about looking up drugs online in the format that you want to see. They should be using words like pharmacokinetics and pharmacodynamics and agonists and antagonists and those sorts of words, not go ask your doctor. Let's talk about the over-the-counter medications. Again, we, by law, by legislation, through their infinite expertise, they have divided drugs into 3 classes. Nutritional substances that aren't drugs, yes, they are drugs. Then those available by prescription only, those are called legend drugs. And then those for which directions by safe use for the public can be written. Those are the over-the-counter drugs. Drugs you can buy at the drugstore. And so these are all regulated differently. My problem with this is that you have to ask your patients specifically about the nutritional supplements they use. Because you go, what medications do you take? Do you have your medication list? And the patient will think that their medication list only involves drugs available by prescription. This is what people think drugs are. And so when you say, oh, are you taking any medications? They say, oh, this right here. And we fail to ask about their excessive use of over-the-counter medications. Maybe they're using a bunch of antacids at the same time that they're taking their prescription medications. Boy, that'd be something we would really, 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 really need to know, that they're using antacids in excess at the same time that they're taking their prescription medication. Or maybe they're just taking way too many Tylenols while they're taking this other prescription medication. Maybe they have a prescription that has Tylenol in it, and then they're taking Tylenol over the counter. They won't tell you about the over-the-counter Tylenol they're taking because it wasn't a prescription, and we'd really need to know this information. There are nutritional supplements that interfere with our metabolism of these drugs, and your patients will tell you this, but they won't tell you that unless you ask. And so the purpose of all of this is not to throw mud at all the people who aren't regulated by the FDA. The purpose of all this is to be a better clinician and be aware that there are people using drugs called nutritional supplements. They're using medications called nutritional supplements. You need to ask them about that. They're also using medications that will be referred to by law as over-the-counter. You need to ask them about that. And then they're also going to be using medications, legend medications, that are available by prescription. And everyone naturally assumes that that's what you're talking about. And so there are 3 different types of drugs that you need to talk to your patients about, not only the nutritional supplements and the over-the-counter medications, as well as the prescription drugs. And again, I've made the point, there's 10,000 bottles of diphenhydramine in there, and yet only 1 active ingredient. And so if you really go to a drugstore, any pharmacy, and you go and you look at the active ingredients on the over-the-counter stuff, you'll notice all those pain medications basically have the same things in them. All right? And they'll mix them together and say they're different, but they're basically all the same. And we call them Me Too drugs. They call them Me Too because somebody puts a drug on the market, like when Advil came out, then Nuprin came out. It was a little yellow and different. No, it wasn't different at all. It was just little yellow ibuprofen. And so when one drug company is successful selling a medication, then another drug company, as soon as they have patent rights to the same generic drug, they're going to do exactly the same thing. They're going to market as something different when in reality it's exactly the same thing. So again, I want you guys to read the labels. What the drug is not what the trade name is. What the drug is actually the generic, because you're going to see one generic drug have all sorts of trade names, and it kind of gets confusing. That's why I recommend looking everything up every time. You get the point. And here's my point, that people are going to overuse the over-the-counter medications. They're going to be, oh, I take all these antacids, I take all this Tylenol, I take all this other stuff, and then why their medications that are prescribed don't work the way they're supposed to has to do with this. And so you have to ask about this when you're taking their history. All right, well, all that being said, let's talk about drugs and pregnancy, especially with a baby infant formula shortage. I would assume that more women would be breastfeeding, and women who breastfeed often need medication, and there is a way to do both. There is this philosophy out there that if you're breastfeeding, don't use any medications at all for any reason, and that is not a good idea. There's always a risk-benefit balance to everything we do in the medical business, and there are situations where women need to breastfeed and take their medication. And so we're going to talk about drugs and pregnancy. A great place to look for drugs and pregnancy is that DailyMed website, not dailymed.org, but the National Library of Medicine, National Institute of Health website. And so anyway, a doctor here, the practitioner here, is trying to convince this person to take this medication, and she's looking at her like she's watched the last 30 minutes of lecture and getting ready to watch the next 30 minutes of lecture. All right, so let's see where all the scare comes from. The scare about drugs and pregnancy comes from the word teratogen. Terato is Greek for monster, and gen as in Genesis, to form from the beginning. In the old days, in the ancient times, we used to call birth defects monsterism. And so if you read books written before the politically correct age, birth defects were referred to as monsterism. And so that's where the word teratogen comes from. So teratogens cause birth defects, but not just any birth defect at any time. Teratogens, there is this timing and place in fetal development that they exert their effects. And so the easiest way to do that, read the words and then look at the chart. And so if you Google fetal development chart, you'll come up with this. I think there's a big one in your notes that you can look at. And let's go through the fetal development chart. All right, at the top is the weeks of gestation since conception. And so here's the first couple of weeks. And then that's considered the zygotic period. And then here is the embryonic period. Between weeks 3 and 8 is the embryonic period. And then the fetal period is from week 9 to 38. I don't need you to memorize that so much. I just want you to see that at the top of our chart is weeks of gestation. First couple of weeks, embryonic period 3 to 8, and then the gestational period, or the fetal period, 9 to 38 weeks. So there's our embryonic period, the fetal period, and the zygotic period. Great. All right, well, if a teratogen affects a zygote, a baby in its first 2 weeks of conception, well, the teratogen just usually destroys the pregnancy. There aren't any organs involved at this point. The whole glob of cells are all basically related to each other. And so in teratogens in the zygotic period usually result in prenatal death. Maybe the woman won't even know she was pregnant. And so when we talk about teratogens, we don't talk about the zygotic period, because if the pregnancy is just completely lost, it does not result in birth defects. All right, so let's talk about, that's why we don't even look at the zygotic period when we talk about teratogens. Okay, now that we're on this part of the embryonic and fetal period, if you have a color chart, you'll notice there's 2 types of abnormalities. There's a major abnormality, and on my black and white, that's the darker line. And then there's some abnormality, not major, but decreased risk of abnormality is what I've put. Maybe minor abnormalities. And so if you have the color chart, the first half is red and the second half will be yellow. All right, so let's see what that means. We have a major abnormality window and then a decreased risk of abnormality window. All right, let's start with arms and legs. And let's take a teratogen that affects the arms and legs. All right, well, if that teratogen is given in the first couple of weeks, maybe we won't even have a pregnancy. If it's given up to week 3, well, maybe the arms and legs won't even be affected. But notice that the arms and legs start to form in the middle of the 4th week and continue to develop up to week 7 and 8. All right, well, by week 9, the arms are fully developed. By week 16, the arms are completely developed. All right, so by about week 9, we have complete development. So let's look at exposure to the teratogen that affects the arms and the legs. And so if the teratogen is given early and cleared before the 3rd weeks, well, we're not going to have any abnormalities of the arms and legs, because the arms and legs aren't being exposed while they're developing. All right, well, now between weeks 4 and 7, this is a major development period for the arms and legs. Between week 4 and 7 is a major development period for the arms and legs. And if we're exposed to a teratogen during that time, then we can expect major abnormalities to the development of the arms and legs. Well, around week 7, and between 7 and 8, the development of the arms are wrapping up, and so if the teratogen begins to be exposed to the embryo around week 8, maybe we can expect some minor abnormalities, but at this point the arms and legs are pretty much well developed. All right, well, after week 9, the arms and legs are developed. And so if the pregnant woman is exposed, if the fetus is exposed to the teratogen that causes an abnormality of the arms and legs, by week 9, well, it's too late. They're not going to affect the arms and legs. The arms and legs have already been affected. And so that's why we see this window for teratogenicity occurring between the week 4.5 and week 9.25. Okay? And so in between the fourth and a half week and the 7th week. If we're exposed to a teratogen that affects the arms and legs, then we can expect major abnormalities. All right. And we know this from something called phthalimide. Phthalimide was marketed back in the 50s to prevent nausea and vomiting, and about 10,000 babies were born with phacomalia, deformed arms and legs. And this is how we know this information right here. I assure you by mistake. All right. So if the mom was exposed during this period, then there wasn't a problem. But moms usually get nausea during pregnancy right in here. That's why we have to be real careful about the medications that we use for nausea. So we've made that point. And so we see this for the central nervous system. The central nervous system begins to develop very early in the 3rd week. And if a teratogen affects the central nervous system, we can expect major abnormalities if that exposure happens between week 3 and 5. Our central nervous systems are always developing until we get about my age, and then it seems to just shrink away. And so if we're exposed to teratogens during the rest of our life, anything that causes brain damage for the rest of our lives, we expect some kind of minor abnormality. Your heart's developing between week 3 and a half and week 6, and so if you're exposed to a teratogen that affects the heart and our exposure is in between week 3 and week 6, we can expect major abnormalities of the heart. The heart's fully developed by week 8 in the fetal period, and so if the same teratogen is exposed after the heart is developed, then it won't affect the heart. And so this is what we want to see from this chart about teratogens, that there is a time and a location that the teratogens affect the body. And that's just based on how the body develops. Your eyes are part of your central nervous system, and so we don't expect that to be too much different. They start developing a little bit later. Same thing with teeth. We'll talk about teeth that affect, we'll talk about drugs that interfere with the development of the teeth. Palate, cleft palate, that's essential and between week 6 and 8, and then past week 9. And so your palate should be fully developed by week 16. If we're exposed to something that interferes with palate development after week 16, we don't expect a major abnormality. We don't expect any abnormality after week 16. And so this is what the chart is supposed to show you about teratogens. A while ago, the FDA got rid of the fetal risk categories because they thought it was confusing, and they came up with something less, I guess more confusing, less clear. And so anyway, I get emails from somebody every once in a while telling me, well, they don't even use category A, B, C, D, X anymore. I'm like, well, that depends on who they are. They don't use these anymore. But I read all sorts of good books and all sorts of guides, and I talk to all sorts of people who use this in their day-to-day nomenclature. And so I thought I'd talk about it today. And a lot of things that I talk about, maybe people will say, oh, we don't want to use that anymore. I'm like, well, you might not want to use it, but you certainly want to know what it is if you see it. And that goes for abbreviations and some of this older stuff as well. And so we divide drugs into A, B, C, D, and X as their risk for the fetus. There really aren't any category A drugs out there. I think Synthroid has grandfathered its way into category A. Category A drugs are considered completely safe in pregnancy. There's no harm to the fetus if you use a category A drug. All right, so guess how many drug companies are willing to guarantee that their drugs are perfectly safe in children? Nobody. And so that's part of the reason they got rid of this category, is that there aren't really any category A drugs out there. Prenatal vitamins, Synthroid maybe. The near entirety of drugs that are actually safe to take in pregnant women are category B drugs. And that's probably okay. Here's the formal. Well, we've given all sorts of given this drug to all sorts of animals and done all sorts of things to the animals with these drugs. We didn't see any problem, but there really aren't any pregnant women out there that want to be part of our clinical study, and we don't want to use pregnant women in our clinical studies anyway. And so this is how something gets its category B designation. We consider category B drugs to be safe in pregnancy. All right, well, category C drugs, we're just not sure. Category C drugs we generally consider to be safe in pregnancy. but there has to be a real good reason to justify any kind of risk to the fetus, to the developing baby. And so these drugs should only be given to pregnant women if the potential benefit outweighs the potential risk. All right. And category C is just like, we're not sure. We know they're not dangerous. We just don't know if they're safe. All right. Category D drugs are when we start seeing evidence of risk to the developing fetus. Sometimes these category D drugs will be drugs that they don't cause teratogens, but if they're given over the long term, they can cause risk and even addiction in the developing baby. So category D drugs can be potentially harmful to the baby. Now, you'll be standing in the delivery room, and baby's getting ready to be born, and they want to use a category D drug right now. Well, you know, again, think about teratogenicity. We're going to use the drug one time on a fully developed fetus. We're not going to expect teratogenicity. And so just be on the lookout for that we will use category D drugs in pregnant women, especially if the risk if the benefit outweighs the risk, and then sometimes a one-time dose at delivery to move things along. All right. Category X drugs, we just keep them away from pregnant women. All right. And women of reproductive age as well. And so category X drugs, the drugs are contraindicated in women who may become pregnant as well. There are certain drugs that are so teratogenic that women are required to take birth control pills while they take that medication, or else at least guarantee that they're not going to end up in this situation right here. All right, well, gee, after an hour of lecture, I'm not sure that I would want to breastfeed and give and take medications at the same time. And so this happens. Thousands of women who take medications won't breastfeed because they're worried about risk, and breastfeeding babies is very important. It's something that we try to encourage in all of our moms, especially right now with what's going on. And so there is a way to take medication and still be able to safely breastfeed. And again, look the medication up on Daily Med, because there is a place about breastfeeding and medications on the Daily Med website. Not all, but most of the medications available to pregnant women are excreted in breast milk, so it's so small, it's not going to adversely affect neonatal health. And so if a medication is safe to use during breastfeeding, well, then the medication should be taken immediately after breastfeeding, and then 3 to 4 hours before the next breastfeeding. And this goes for pumping as well. So if you're pumping, you can take the medication after the pumping, and then well before the next pumping. All right, and so that's with safe medications. And again, Daily Med has an excellent website, place on their website to talk about nursing mothers, drugs, and lactation. Because most of the drugs are going to be cleared from maternal circulation after 3 to 4 hours. So if the mom can wait 3 or 4 hours before the next feeding, before the next pumping, then that medication should not be in the breast milk. Let's talk about kids. Another complicated thing is children and drugs. All right, so kids are different. They're not little adults. That's the first thing they taught us in pediatrics. Please do not believe that kids are just very small versions of adults. They're not. They're different. They have kinetic differences. And so because of these differences, pediatric dose information is given by the manufacturer in the package insert. Now that gets complicated. However, the manufacturers won't test their products on kids, even when studies have been published in the medical literature. So this is very interesting right here, that a manufacturer will come out with a drug and they'll go to the FDA for approval, and they're like, well, we didn't approve this for kids. We didn't do any clinical trials on this drug in kids. And so it'll say, not for use in children. Do not use in people under 18. Why? Because they didn't do any clinical studies on anybody under 18. And so the package insert will say, do not use in children under 18. All right, well, then you're a pediatrician at a pediatric hospital, and maybe you've seen kids get that medication by mistake, and the kids are fine. And maybe the kids, okay, well, don't use it in an 18-year-old. Well, we can use it in a 16-year-old, and maybe they try it out, and that works okay, and maybe they try it in a 12-year-old. And so you'll notice when medications come out from a manufacturer, the manufacturer will say, oh, well, don't use it in kids. And then you get in a pediatric hospital and they're using it in kids. Why? Because sometimes studies in the medical literature will support that the drug is completely safe, but the manufacturer did not send the information to the FDA, and the FDA is saying, oh, well, it's not indicated in children. So then when we're doing this down here, this is considered off-label. When professionals within their specialty are using drugs off-label, not only is that okay, that's actually very common. The perception that we get on TV is when doctors use drug off-label, that there's some kind of quack, and recently we got that here in Maui. We're not going to get too fired up about that, but we did have some very respected physicians using drugs off-label, and it turned into this big political brouhaha, and I can assure you they've never gotten to this part of the lecture. And so there are clinical specialists who are pediatricians who use the medications in an off-label manner for this reason right here, because manufacturers will not test their drugs on children because that's just not something financially safe for them to do. So then they rely on the pediatric institutions to come up with this literature. But the FDA is not structured in such a way that they're going to change the labeling, change the indication because of what's going on down here. All right, so if you ever end up being a politician, don't start coming down on healthcare professionals, don't start coming down on specialists because they're using drugs off-label because you will just look foolish. All right, eventually we're going to get into mathematics around here, quite simply for this reason, because when we start talking about medications for children, the doses are going to be stated as milligrams per kilogram. And so when a lot of pharmacology just involves mathematics, and in this course I like you guys to do mathematics the way we learned in physics and the way I do math now using dimensional analysis, and we'll get to that eventually. When I was taking care of children, when I was doing pediatrics, you guys, you moms expected me to do my math 100% correctly 100% of the time. And so now that is my demand of you. Everyone in this class needs to do their math perfectly. And if you can't do the math perfectly, then you need to be accepting of the fact that you're going to interact with healthcare professionals who can't do math. And one of those people might be you. And so you got math, you better got math. You're going to need math in the professional pharmacology business. All right, let's talk about geriatrics. The field of geriatrics applies to people over 75 years old, but that's an arbitrary definition. I'm not going to tell you how old I am, but I have presbyopia. Presbyopia is old eyes. Your eyes focus slowly. And so even though I'm well below 75 years old, my eyes are undergoing geriatric changes. And so geriatrics is just quite simply the physiologic change, studying the physiologic changes that occur as we age. But for the purposes of law and PowerPoint slides, 75 years old. You're over 75 years old. Oh, your geriatrics applies to you. All right, so this is what's confusing for people. Even though they might look skinny as an old person, as a percentage, less of their body mass is actually fat. I'm sorry, less of their body percentage is actually lean. They have increased fat as a percentage. And so when you look at a normal, healthy individual at this age, at a normal age, and a normal, healthy individual at an older age, they might look the same, but the older person has more fat, quite simply as a percentage of body mass. They also have a reduced total body water compartment. They also have decreased serum albumin levels. So the decreased serum albumin levels are going to change their protein binding interactions. The reduced body water is going to change their volume of distribution compared to another person. Their increased fat as a percentage of body mass is going to change the way they metabolize fat-soluble drugs. And so these are the things that we need to keep in mind with the elderly. Little kids are not just tiny adults, and older people are not just older adults. There are kinetic changes between a child and an adult and then a geriatric adult. And so those are things I want you to keep in mind. All right, so we talked about all this kidney clearance business. Your liver tries to make things, and the rest of your cytochrome enzymes try to make things water soluble so your kidneys can get rid of them. Well, as we age, our kidneys quit functioning the way they used to. And because the kidney is the major organ for clearance of drugs from the body, as we get older, our renal function declines, and that means we have to adjust the dose of some medications based on kidney function. And so you'll look at a medication. If you look up your medications like you're supposed to, you will realize that some medications will say, oh, well, they need to be adjusted for the creatinine clearance. And it'll say geriatric considerations, adjust dose for creatinine clearance. So there's the creatinine clearance right there. You don't have to memorize it. You can put it on a spreadsheet somewhere if you want. 140 minus the age times kilogram divided by 72 times the serum creatinine. This is rather arbitrary. This is not exact. It's kind of abstract. There is a pounds. There's 2.2 pounds per kilogram, so maybe the formula will be a little bit different. There'll be a different denominator if this says pounds, and we'll teach you to do all that math here pretty soon. All right, so this is the creatinine clearance. I just wanted you to see what the equation looked like in case you see it again. But this is what I want you to know about the creatinine clearance, is because as we age, our renal function declines, then there are certain medications that we're going to adjust the dosage based on the creatinine clearance. And it's, creatinine clearance is not an exactitude, it's an approximation of renal function, and it's commonly used in pharmacology, especially in the field of geriatrics. All right, well, that's enough basic principles in pharmacology for one semester. When we come back, we're going to start talking about math and terminology. And so until then, aloha.